Well, hello, everybody. My name is Garrett Schmidt, and I'm the managing editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Topcon Screen. And it is called Closing the Gaps, the Reach Model, Population Health, and the Diabetic Eye Exam. I'm very excited to hear from our speaker today, who I'll introduce in a moment, because this is a really exciting topic, and he's got a lot to say. I got a little sneak preview, so it's a good presentation, so looking forward to it. Real quick, a few items of note before we jump in. This is a traditional webinar format, so everybody's joined today in listen only mode. You don't need to worry about muting your microphone or turning off your camera or anything. We can't see you, so rest easy. But we are glad that you're here. And while you are here, we do want to hear from you, though. And so there's going to be an opportunity toward the end of the presentation for Q&A. If you have a question at any time during the presentation, you can submit your question. You have a little attendee control module with an area for questions, which is different than the chat. So don't drop your questions in the chat. Put it into the question area, and we're going to get to as many of those as we possibly can during the allotted time today. If we're not able to get to yours, someone will reach out via email afterwards and answer your question. So up until the very last minute when we're signing out, go ahead and ask your question. We'd love to hear from you. And finally, today's session is being recorded. So we're going to send out, after we're done, I'm going to send out a link to the recording as well as a place where you can download the slides and get in touch with the team. And that'll be about an hour or two probably after the conclusion. We've got a little processing to do, but that will go out to everybody. So even if you had to drop early, or some folks that weren't even able to make it but registered, they will all get it. So without further ado, I wanted to briefly introduce our speaker today, Mr. John Bartolovich, and he is the Healthcare Economics and Reimbursement Manager with Topcon Healthcare. So welcome, John.
Thank you very much, Garrett. It's a pleasure to be here, and welcome everybody. Good morning, good afternoon, depending on where you're at today. I'm going to drop off camera, so I'm not distracting anybody as we do the presentation, but a little bit about my background. I have been in healthcare sales for a little over 30 years. Most recently, the last 12, I have been in the diabetic eye exam space with an emphasis on population health. Topcon has over 80 years experience in healthcare, working with eye care professionals as we provide equipment, both diagnostic and image management solutions to eye care professionals around the world. So if you've been to an optometrist or an ophthalmologist lately, you've probably been tested or seen a piece of our equipment. Recently, in the last 6 years, Topcon has started our Topcon Screen division, which is dedicated to bringing the diabetic eye exam to the primary care office. So our goals today, our learning objectives and goals today are a brief overview of the ACO REACH model, the effects of health equity and social determinants of health on healthcare, the importance of addressing health equity and social determinants of health under the ACO REACH model, as well as how point-of-care testing positively affects the REACH model, health equity, and social determinants of health. So social, economic, and geographic disadvantages create significant disparities in healthcare, such as lower quality of care, lesser health outcomes, increased utilization of expensive services that may have been preventable. So the Accountable Care Organization, Realizing Equity, Access, and Community Health, or ACO REACH model, has been developed and will test ways to address health equities by focusing on alternative payment structures that could better support accountable care delivery and care coordination. Chief among these is the ACOs have to develop a health equity plan, which will provide detailed information on identified health disparities and its intended actions to remedy such inequities. The ACO must also apply health equity adjustments to performance benchmarks, capture demographic and social needs data, and implement beneficiary engagement incentives. Now, one of the other outputs here is with the ACO REACH model, CMS has streamlined the quality measures, and the ACO REACH model participants will be judged on 4 out of 5 quality measures. The first of those is the risk standardized all condition readmission measure, which measures how many hospital stays result in a readmission within 30 days after patient discharge, and that will affect all ACO REACH participants. The second is the all-cause unplanned admissions for patients with multiple chronic conditions, and that measures unplanned hospital admissions among Medicare fee-for-service beneficiaries 65 years of age and older with multiple chronic conditions. And again, this also applies to all REACH ACOs. There's the third, days at home for patients with complex chronic conditions, and that measures the number of days that adults with complex chronic disease spend at home or in the community setting. And this one will apply only to those ACOs that are high needs population ACOs. The fourth is timely follow-up after acute exacerbations of chronic conditions, and it is defined as the percentage of acute events related to one of 6 chronic conditions where follow-up care was received within the timely timeframe recommendations. And those diseases are hypertension, asthma, heart failure, coronary artery disease, COPD, and diabetes, and those apply only to the new standard and new entrant ACOs. And then lastly, the CAHPS survey, which will again apply to all of the ACOs. So what else has changed? Well, as you can see on the screen, there's 2 new payment models. One is going to be a 50% risk, lower risk sharing arrangement for both upside and downside. The other is going to be 100%, and there are payment options available for both. But the real keys here are that with the changes, providers need to represent at least 75% of the ACO's governing board and voting rights. And that's up from 25% from years past. Health equity is also a strong focus, and all participants must create and execute health equity plans. And CMS is going to measure and incentivize equity. They're basing some payment options and some bonus opportunities on demographic data that is collected and utilized. One other thing is, since we are looking at capitated costs, the risk scoring methodology is being adjusted as well, and ACO REACH models will have their risk adjusted to better reflect the cost of caring for medically complex beneficiaries. And this will take place before the 3% cap. So here we are, we have a polling question number 1. And your option, the question is, how many of your organizations are participating in a REACH ACO? Option A, we're all in. Option B, we're exploring. C, we're interested. D, never, not gonna happen.
All right, John, we've got the questions up and we're getting answers in. So we're going to give everyone about 3 or 4 more seconds. 4, 3, 2, 1, and we're going to go ahead and close it out, and then I will show the responses. John, are you able to see the responses from your end?
Let me turn it on and we'll see. I could not.
Okay, so I'll read the results here. For we are all in, that is 53%. So that's awesome. Exploring is 13%. Interested is 16%, and the never is 18%. So looks like a majority of folks are in. Very good.
Fantastic. Well, as we've discussed, health equity is going to be a huge component of the ACO REACH model. And so to move forward, let's give a couple of quick definitions and some examples. Health equality gives everyone the same opportunities for care. Everyone gets the same healthcare funding and services. I saw at a presentation one time an example of a slide where there were 5 people on the screen and they each got a 36-inch bicycle, but some of the people were very tall, others were very small. So it was, yes, we have equal access, but it's not the care we actually need. Health equity, on the other hand, is the state in which everyone has a fair and just opportunity to attain their highest level of health and takes into account different cultures, access to resources, and socioeconomic status. And then health disparities, we're all aware of what they are. It's just a difference that is unjust and preventable. And I'm going to give some examples. And as we move forward, most of my examples are going to tie into diabetes and health inequities there. But some of the disparities out there that we see are Black men are more likely to die from prostate cancer than white men are. An individual's life expectancy can vary by as many as 25 years between neighborhoods in the same city. So, your zip code oftentimes is way more important than your genetics when it comes to healthcare. We see similar outcome gaps in infant mortality, obesity, violence, and chronic diseases. Rural communities have higher rates of preventable conditions, including diabetes, some cancers, and obesity compared to urban residents. Racial and ethnic minorities have greater proportions of chronic disease and premature deaths when compared to whites. So the message here is health equity needs to be addressed, and health is the foundation for a healthy and economically vibrant society. Social determinants of health have the biggest impact on these inequities, and some examples are, things such as safe housing and transportation, educational and job opportunities and income, access to nutritious foods and physical opportunities, language and health literacy. It's important an interesting statistic is that 68% of all Americans have at least one social determinant of health challenge, and 52% have moderate to high social determinant of health risk in at least one category. So, for example, a person who doesn't have access to grocery stores with healthy foods are less likely to have good nutrition. This raises their risk of health conditions like heart disease, diabetes, and obesity, and lowers their life expectancy relative to people who do have access to such items. Another would be people that live in unsafe neighborhoods have limited opportunities for physical activity, which again is going to affect their health. So it's clinically important to create programs to help identify health inequities and address social determinants of health. Research shows that medical care accounts for only 10 to 20% of outcomes. Going back to, again, that your zip code has more of a bearing on your health than your medical outcomes and genetics. As an example, African American, Hispanic or Latino, Native Americans, Pacific Islanders, and Asian Americans are more likely to develop prediabetes and type 2 diabetes. US adults have a 40% chance of developing type 2 diabetes, but if you're a Hispanic or a Latino, that jumps up to 50%, and you're likely to develop it at a much younger age. Diabetes complications are going to hit the Hispanic and Latino population a lot higher as well, and harder as well, because they have higher rates of kidney failure caused by diabetes, as well as vision loss related to their diabetes and blindness. Adults who experience food and nutrition insecurity are 2 to 3 times more likely to have diabetes than people that don't. Experiencing food insecurity while being a diabetic leads to higher A1C levels, diabetes-related complications, hospitalizations, and poor mental health. And again, tying this back to REACH, we want to eliminate those unplanned admissions. We want to address these concerns. It's also important to note that while lower nutritional foods can cost less and provide more calories, they also can cause hyperglycemia, which can lead to increased risk of diabetes related to complications like nerve damage and vision loss. Healthcare costs twice as much for people with diabetes as it does for those without. And unfortunately, because of social determinants of health, there are many patients out there who have to decide on a daily basis to treat or to eat. They're either going to treat their diabetes or they're going to put healthy food on the table. This is why the U.S. health system needs payment models like the ACO REACH model that are going to address health equity issues. Poll question number 2. I have seen an eye care professional, A, within the last year, B, within the last 6 months, C, within the last 4 weeks, D, I can't remember the last time.
Okay, we've got the question is up. We've got answers rolling in. We'll give this another few seconds. In 4, 3, 2, 1. I'm going to close it out. All right, and then I'm sharing the responses here. Okay, it looks like within the last year it was 54% of the audience here. Within the last 6 months was 19%. Within the last 4 weeks, 10%, and then I can't remember the last time was at 17%.
Well, those of you who have been to an eye care professional in the last year or weeks or months, you probably more than likely were tested with at least one piece of Topcon technology. So I wanted to add this question because for most diabetics, unfortunately, they have not seen an eye care professional in the last year. So we've talked about how inequities affect patients with diabetes. Now let's look at how diabetes affects the population in general here in the United States. 37.3 million patients in the US have diabetes. That's 11%, 11.3% of our population to be exact. 28.7 million have been diagnosed. And unfortunately, there's 8.5 million of us out there that don't know that they have diabetes. And that's according to the CDC. It's also important to note that many patients that suffer with diabetes also have multiple chronic conditions like hypertension or obesity. They're at a higher risk for complications of the kidneys, the heart, the eyes, and lower limb amputations. And that's why the ADA recommends that these patients get screened on a regular basis for their A1Cs, their kidney disease, cardiac events, lower limb amputations, and vision loss. Point of care testing at the primary care level is a very, very effective way to eliminate healthcare inequities as well as close care gaps. It generally fits within well-established workflows with little or no disruption. And currently, patients are receiving point of care testing for their A1Cs, their kidney function tests, their cholesterol test, as well as a foot exam at their primary care office. I'm going to date myself here. I'm old enough to remember when primary care physicians had to send out their A1Cs and experienced a lot of the same gaps in care that I'm about to show you in inequities when it comes to the diabetic eye exam. Point of care testing improves patient engagement. It gets you your results back quicker. It eliminates the inequities of a patient and social determinants of health so that patients don't have to go to another appointment or take more time off work in order to get this routine testing done. When we look at STAR data, reporting data, we see that 95% of patients with diabetes were monitored for kidney disease back in 2018. That was 20% higher than those who were monitored for their diabetic retinopathy exam. And when we look at when it was gauged against ACO 41 measure, which again was the eye exam, it's 40% higher. And it's not that we value kidneys more than we value eyes, it's point of care testing. It's a lot easier when the patient is in the office to go ahead and get that done, get that blood work done, do the urine analysis, than to send them out to a lab or someplace else to get that done. And the issue with the diabetic eye exam is that is predominantly done as a referral. Diabetic retinopathy is the leading cause of blindness among working adults in the United States. And as we showed earlier, when you look at the statistics and how it affects Asian Americans, Pacific Islanders, African Americans, Latino, Hispanics, Native Americans, a lot more than it does the white population, you can see how these statistics can be just devastating. 40% of diabetics, when they go in and have this exam done, will have some level of pathology, be it diabetic retinopathy or some other type of eye disease. And of those, 10% of them are going to be at immediate risk for blindness. The biggest issue is patients with diabetes that have retinopathy, initially there's no symptoms. So they think that their vision's good and their eyes are safe, when in essence, it's a hidden disease process that's stealing their sight. So once a patient becomes symptomatic, they start moving from mild to proliferative diabetic retinopathy. They start to experience flashes of lights, floaters, spots. And again, as with most conditions, the earlier we detect this, the better our patient outcomes are. And in fact, 95% of all vision loss can be prevented simply by doing this annual exam annually and following up whenever we detect any pathologies. Despite everything we know about diabetes and diabetic retinopathy, however, up to 50% of diabetics were not tested for retinopathy in the past year. Let's look at the current process and to gain a better understanding as to why. As the process works in most offices right now, the patient comes into the office, they're there for their visit or their screenings, they get them all done. But when it comes to the diabetic eye exam, their primary care physician refers them out to an eye specialist. Typically, one of three things is going to happen here. First and foremost, the patient's going to go to the appointment, and then the office is going to get a report sent back to them, and they can go ahead and close the care gap that the diabetic has had this exam done. The second outcome is patient goes to the eye care professional and gets the exam done. However, the report doesn't get transmitted back or it gets lost. And the office staff spends an awful lot of time, wasted time, chasing down charts. And the last thing that typically happens is the patient doesn't go. And these are typically because of social determinants of health. They don't have transportation. They need to take time off of work. They're the only breadwinner. So that causes problems. They have childcare issues, or maybe they're taking care of an elderly parent, or it's a grandparent taking care of an elderly child that has an older child that has some sort of condition that requires constant care. So these care gaps, they negatively impact the healthcare system. physicians, the ACO, the payers, but most importantly, they negatively impact the patient. And as we've talked, when complications get to advanced stages, the cost of negatively impacts utilization. And again, that is something that we're trying to avoid, especially in the ACO REACH model. I always like to point out in all my conversations, but especially here as we're focused on the ACO REACH model, not every patient in a provider's panel is going to be part of an ACO REACH model. Many of them are going to have private insurance. They may be a straight Medicare patient. They may be a Medicare Advantage patient. Who knows? We do know that they're not all going to be part of the ACO REACH model. What we do know, though, is that many plans consider this one of the hardest quality measures to close. And this care gap is going to vary depending on your patient population, as well as the payment models that you're dealing with. When we looked at the claims data going back in 2018, 52% of patients that were part of the Medicare Shared Savings ACO had the documentation for the eye exam in their chart, where 72% of patients in Medicare Advantage programs had the documentation. Now, I will also note that the ACO 41 diabetes eye exam measure was removed from subsequent years, but that was because of administrative purposes, not because of lack of efficacy in the exam. So diabetes and undiagnosed diabetic retinopathy have some tremendous consequences and expenses when we look at things. Some of these impacts are that the cost of care to the patient and to the health system in general are increased. Again, large number of patients have no idea that they have pathology because mild retinopathy has no symptoms. So they think they're fine. And it's once they start seeing spots and flashing lights and floaters that they need to get urgent care. And that treatment cost can be as much as $10,000 annually to treat a patient with diabetic retinopathy. Typically, it does run between $600 and $1,000 annually, but it is important to note that it can exceed $10,000 annually. And this doesn't take into effect the societal impact or the mental health impact on the patient themselves. Point of care testing is not a new thing for retinopathy. It's been around for 23 years. The Indian Health Service and Jocelyn Vision Network were established in 2000 to provide high quality annual diabetic exams to patients in need. And they significantly contributed to a decrease in diabetes-related vision loss and blindness. Same thing goes with the Veterans Administration. They've shown that point of care testing can reliably determine the level of diabetic retinopathy. It gives them a chance to engage with their patients. And again, it has a positive impact on utilization and cost savings. It works in primary care as well. I'm going to use an example from the Topcon world, one of our partners, Crozier Keystone, one of the largest health systems in the Philadelphia area, partnered with Topcon and Vantage Eye Care to institute a program. They started off with piloting it in 2 locations. And that's typically what happens when an enterprise is looking to move into this. They'll look at 2 to 5 sites to target to make sure it's going to be viable. Crozier looked at 2 sites, and what they found within the first 80 patients they screened, 37% of them had abnormal studies. That led them to go ahead and immediately expand their program from 2 locations to 19. I also like to point out that these were patients that weren't going to see an eye care professional. So that's the key. That's what these programs are designed for. Those patients who aren't under the care of an ophthalmologist or an optometrist for their diabetic retinopathy. So very important to note. The benefits of the program were that it reduced utilization, it closed care gaps, it eliminated health inequities and disparities and social determinants of health, because no matter what, the patient was able to get that care at the point of care with their primary care physician. The medical director of primary care for Crozier said that this is an effective frontline defense against diabetic retinopathy. And I also like to point out that Topcon screen not only identifies the 4 levels of diabetic retinopathy and macular edema, but it can also identify up to 30 other pathologies, such as increased cup to disc ratio, drusen, AMD, things of that nature. So we saw how the system works in most offices. Here's how it works with Topcon screen. 4 simple steps. Patient is at their primary care office. The staff takes the patient images and treats it just as if it was a vital sign. Those images are then sent via secure encrypted data transmission, HIPAA compliant system that's been in use over 10 years in the eye care space. There, it's read by a board certified eye care professional licensed in the state of the office, and a report is generated. That report is then returned to the practice, typically within 24 hours. We guarantee it within 48 hours via the same portal. Or if you require, we can also do an EMR integration as well. We currently don't charge for that integration, but your EMR provider will. The practice bills the insurance for the service and then pays Topcon a per patient fee for each report that's generated. So as I said, 4 simple steps. Topcon screen is a camera agnostic program. And by that, I mean, if you already have a retinal camera, it's very likely that we can hook it up to our Harmony platform. If you do not, we do offer 2 solutions, 2 non-mydriatic retinal cameras. The first being our Signal handheld. It's a portable camera, and it's typically best for small offices or mobile providers. And I always like to point out that all handhelds are going to require that the patient sit in a darkened room for at least 5 minutes for natural dilation. The second option is the Topcon NW400 robotic tabletop camera. Does not require that the patient sit in a darkened room for 5 minutes, does not require drops, and within 2 minutes, both eyes are captured and ready to be sent. So it's important to note that no matter what your circumstances are, we will work with you to determine what the best camera options are. Tying this all back together, what's the impact on the REACH model? Well, first and foremost, we're providing the right care at the right time for patients. We're improving the access. We're improving the affordability. We're eliminating inequities and social determinants of health. We're lowering the overall cost of care by early detection. One of the other points I like to point out is because on the REACH model, you will be receiving RAF payments, the impact of increasing a RAF score by just 0.25 is $2,400 per member per year. When you look at moving a patient who is a diabetic without complications up the scale because they've developed retinopathy of some level, that score will increase and be worth roughly $1,800 per member per year with the diagnosis. Financial impact on the practice is immense. We discussed how it's going to impact your RAF scores, but as I stated earlier, not every patient is going to be a member of your ACO REACH model of the providers. So there are HEDIS bonuses out there that are affected. Star ratings, quality measures on other payer contracts, and any other capitated plans that you might be participating in. The eye exam for diabetics applies to all commercial Medicaid and Medicare contracts. And as a reference, in 2019, the average star rating for the eye exam was 3.7, but star bonuses did not begin to be paid until 4 stars or higher. So wrapping things up, despite addressing the hardest measure to meet and implementing point of care diabetes eye exams, it's been challenging not only for the patients, but also for the practices. And the reason for that is you have barriers that you need to overcome to institute these as well. And Topcon Screen helps you to eliminate those barriers. There are 2 components to our program, the camera and the diagnostic report. You've got 4 options when it comes to the camera. If you have your own camera, odds are we can work with you. If not, you can purchase one from Topcon, you can rent one from Topcon, or we also have a 0 capital model, which allows you to bring the equipment in on a minimum exam commitment. The other component is the diagnostic report. Each time a report is generated, the practice pays a fee. Those fees covers getting the image from point A to point B, the interpretation fee charged to us by our reading center, and the fee to get it back to you. And the fee for the report itself, period. There's no other fees. We don't charge you for training initially. We do not charge you for customer support. There are no more additional software fees. Success with our program begins with 2 things: our onboarding process, our client success team that works with your practice to make sure that this is a viable solution, and also my team, the healthcare economics and reimbursement team. During your first 90 days with Topcon, we want to eliminate your concerns over reimbursement, and we do that by helping to offset any concerns on a denied claim. If you were to receive a claim that was truly denied for service, not because of a coding error or anything like that, Topcon Screen will reimburse you that report fee up to for your first 25 denied claims. And the reason we do that is we truly want to be your partner in eliminating blindness. And with that, I thank you all. That is the end of the presentation. And Garrett, if we have questions, we can try to answer them.
Okay, all right. Well, yes. First of all, thank you, John. That was very informative. I know I got a lot out of it. And yeah, we did have some questions that came in. So in no particular order here, I'm going to answer some of the, or ask you some of these. I'll let you answer them. And if you do have a question, by the way, for John, go ahead and submit it now using the control module. There's an area for questions specifically that's different than the chat. So let's dive in here. First question is, and again, these are no particular order. How often does this exam need to be done for patients?
The ADA recommends for a type 1 diabetic that the exam be conducted 5 years after their initial diagnosis. So typically that's going to be with, a juvenile. So it's probably going to be around the 11, 12 years of age mark. And then they want it done annually after that. For type 2 diabetics, it is recommended that this exam be conducted annually from the time of diagnosis.
Got it. And next question is, and I guess somewhat related, are the requirements different for type 1 and type 2 diabetes?
Again, once the only difference between the two is type 1, it's 5 years after diagnosis. Type 2, it's immediate upon diagnosis. That needs to be done annually.
Got it. Next question here is, what is the overall economic impact of diabetes and its complications?
It immense. But the most recent data we have is from 2017. And at that time, it showed that the cost for treating diabetes in general, overall economic impact, if you will, was $327 billion. 237 of that billion dollars was in direct medical cost, and 90 billion of that was predominantly due to lost productivity. One thing that is important to point out, as we stated in the presentation, somebody with diabetes, their healthcare costs are generally 2 to 3 times more than those of somebody without diabetes. I'm just looking over a quick statistic I have here. $16,752 last year to treat a diabetic annually, compared to $9,600 for somebody who was not a diabetic.
Gosh, well, that just gives you an implication of the importance of catching this early, right?
That when you consider you've got 37 million people out there that either have diabetes and know it, or and some that don't, the cost is staggering.
Goodness. Okay. Moving on. What impact, if any, will CMS's new ruling released yesterday regarding fee-for-service adjustment impact your business model for primary care physicians using your Topcon product? Now, you may or may not know the answer to that, but in case you're familiar with that.
If this is in regards to their discussion on RAF scores, I really don't know it's going to impact that much, because they're supposed to already be vetting and making sure that we're not seeing any malfeasance, if you will, when it comes to RAF scores. It's important that we document to the highest level of severity a patient's condition, but it's also important that that be accurate coding. So as long as it's an accurate code and it is a disease state that the patient has, it shouldn't affect our business model at all. If that is not the question you were asking, at the end of the presentation, my contact information will be there. Please feel free to forward me or hit me with an email with what you were specifically looking for, and I promise I'll do the research to try to get you an answer.
Very good. Okay, next question. Where can we find information on pricing for leasing versus purchasing the handheld camera?
You can go to our website, topconscreen.com, and you can be connected with a sales representative, or at the end of the presentation, there will be my email address and my phone number, and I am more than happy to put you in touch with the appropriate sales representative.
Yeah, and same here. If you needed to reach out to me directly, I'm happy to put you in touch with those guys as well. Okay, next question here is, on a strict Medicare fee-for-service basis, what volume is required in a practice to break even?
Typically about eight exams a month. And that would be including if they were renting a camera.
Okay. Next question here is, you may or may not know this off the top of your head. What is the CPT code used, and what is the reimbursement amount?
There are three CPT codes that are used out there. The first one is 92250, and that is for fundus photography with interpretation and report. CMS does not pay on that exam, on that CPT code, but most primary or private insurers do. So that would be one I would recommend talking with your payers and see what their contract, what each contract has for their level of payment for that. CMS typically is paying CPT code 92228, and that roughly generates I want to say $36 as a national average, but I'd have to get back to you on that. And then the last one is 92227, and most plans aren't really doing much with that one. It's a low reimbursement amount.
Well, I'm impressed, John. You pull that out of your head like that.
That's my job.
That's a good one. Okay. Next one here is, What have you found to be the receptivity of primary care physicians on the Topcon capabilities?
I've been in this space for 12 years. So 12 years ago, there was limited to no receptivity. And as time has gone on, and as organizations like NCQA and the HEDIS scores and CMS with models like ACO REACH are putting an emphasis on lowering utilization and improving access, we're seeing this receptivity grow immensely. When you also factor in that Topcon's the only company out there that can and will offer you a minimum exam commitment contract, whereas you will have no capital fees for your equipment. You will just pay for an exam. You'll commit to a number of exams annually and pay that fee for those. So that makes it a lot easier when you don't have to come up with any upfront cash or anything like that to go ahead and get started.
Very good. Next question here is, and this is kind of a situational question, is in your screening workflow, there are two practices involved. If the patient has everything done at the eye care doc, it's only one practice involved. Does your process entail extra claims costs to the ACO by involving two practices?
No, because actually it is still only one practice involved, because the primary care office is using our reading center, and we're just charging them the exam fee. So they're billing the entire amount for their insurance, and it's really, it's only one practice. Really, it's two practices when you look at the traditional model, where primary care refers out to a ophthalmologist or an optometrist. Now you've got the patient has had one copay at their primary care office, and now another copay, which is typically going to be more because it's a specialist office at the ophthalmology or optometrist.
Good, that's good clarification. Speaking of clarification, another question did come in to this regard. It says, please clarify, with your model, does the PC practice bill for the photo and the eye care professional bills for the, I'm sorry, let me read this again. With your model, does the PC practice bill for the photo and the eye care professional bills for interpretation, with the PC practice paying a fee for the interpretation, or is the fee what the eye care provider would bill a payer?
So under our model, the way it works is you're contracting with our reading center. So your office is going to bill the global amount for the CPT code. You're going to pay us a $25 fee per exam for that read. And we bill no insurance. That's all done by the practice. I hope that answers the question.
Yeah, if it doesn't, reach out to us, later. We'll get you some clarity. And there's actually a second part of that question. It says, also, can a PC clinician get reimbursed for interpretation, or only the eye care specialist?
You are getting the interpretation from Topcon in our reading center, which is housed by licensed eye care professionals, and they will be licensed in the state of your office. So for instance, I live in Ohio, and if I was a primary care office, the reader that would be reading the exams for my office would be licensed in the state of Ohio. So that's all part of our reading center. There's that's part of the fee, and you bill the global amount. There's no TC split, no modifiers, anything of that nature.
Very good. Next question in is, what is the exam minimum?
That is really going to be dependent on, what type of camera we're looking at. Is it a handheld? Is it a desktop? But we really like to focus it on gaps in care. So if you have an office and they have 1,000 diabetics, and 200 of those diabetics are going to their eye care professional, and the reports are getting back to the office, that leaves a gap in care of 800 patients. A minimum commitment of 200 is not going to help you close that care gap It's not going to help you attain your HEDIS bonuses or any quality star measures. So we work with you depending on how many diabetics aren't getting that exam to determine the best possible program for you. So long story short, it all depends.
Very good. And by the way, the individual who asked the last question that you weren't sure if you answered said that clarified what they were asking. So thank you.
Fantastic.
Okay, next question here. They keep rolling in, so we'll get to as many as we can. So ask your question if you got them. For cameras not purchased through the Topcon program, but a handheld camera, is it possible to utilize Topcon programming and image reading on a contract basis?
Yes, it is. And that would result in a lower exam fee. I'm sorry, that would, yes, it is. Right now, I'm only aware of one camera that we do not, we can't support. So it would be dependent on what that camera is. Yeah, but there's definitely a question that our sales representative can answer for you.
Great. Next question here is, if interpretation is billed by the PCP, not the vision specialist, will that not meet STAR HEDIS requirement?
NCQA feels that this meets it because your interpretation is being done by an eye care professional. Our reading center is staffed by licensed, board certified eye care professionals. So there is no reason it's not accepted by NCQA or STARS.
Great. And next question, and actually this is, I think we're going to wrap up with this one, and actually this is a good one to wrap up with, is will this subject be discussed on a further Eye on Healthcare podcast?
We most certainly, the last one dropped today, so I'll shamelessly plug that. But yes, this is definitely something that we will talk about on future episodes of the Eye on Healthcare podcast.
Very good, very good. Well, thank you so much, John, and for this presentation. It was very eye-opening, no pun intended, and and look forward to hearing from some more. We'll try to do some more webinars for you guys here in the coming months, and we'll let you all know when and if that's happening. As we wrap up here, I wanted to encourage you all to visit the Topcon Healthcare virtual exhibit booth. And the way you do this, if you go to vbcexhibithall.com, and there will be a direct link in the slides as well. But if you go here, you can read about what they're doing, familiarize yourself a little bit more about some of their products, and get in touch with a sales individual if that's what you're looking to do, or ask questions. So there's a lot of resources there. That's also where, by the way, vbcexhibithall.com in our library is where you'll be able to access the recording long term. So I'm going to send everybody a recording, or a link rather, to the recording and to the slides when we get done here in the next hour or two. But if for some reason you don't get that, or a couple weeks later you want to review it, if you go to our library, you'll be able to watch it again and get in touch with them. So just visit vbcexhibithall.com. And as we wrap up, again, thank you, John. If you would like to reach out to John, his information is here directly, and he can answer any of your questions that we may not have gotten to today, or put you in touch with a sales rep if you'd like to get a direct quote, or you can reach out to me. I'm happy to facilitate an introduction for you and put you in touch with the right folks. So thank you all again. I appreciate you spending your afternoon with us. Thank you, John, and we'll see you guys next time.
Thank you, everybody. Have a great day.
Bye-bye.